Hello, everybody. This is Dr. Shahrokni. I'm a geriatric oncologist with more than 12 years of experience taking care of older adults with cancer. Today, I'm going to talk to you about colorectal cancer screening in seniors. So, the old dogma was that early detection is always better. This was true for patients, family members, even some doctors that, let's screen more, let's do more tests, and let's do more imaging. And let's see if one has cancer early so we can take care of it so the patient lives longer and so on. This deemed to be a simple universal good. Find it early, take care of it, and enjoy a happy life. However, the new reality looks into benefit as its relationship to time. So now we understand that for older adults, the decision is a complex calculation. It involves weighing the time that it takes for screening to provide this benefit against the patient risk of that procedure or life expectancy or other health priorities. So the focus has shifted from looking at chronological age alone to a physiological age. So as we age, the benefit of colorectal cancer screening or cancer screening in general decreases. And on the other hand, the risk of colorectal cancer screening, like colonoscopy, increases at times substantially. So when you're 65, the benefit in most cases, again, not all cases, but in most cases, outweighs its risk by a substantial margin. And obviously, as you age, let's say if you're in your 90s, the risk outweighs its benefit, again, in most cases, substantially. And there's a break-even basically point, which is somewhere between 75 to 85. It's not very clear whether it's going to be 80, it's going to be 77, it's going to be 82. And this is the area of personalized decisions. And we're going to talk about that in somewhat more detail. But this is how you should look at these things. So as we age, the benefit of certain procedures and tests decreases. And on the other hand, given our aging body, given our accumulative comorbidities and illnesses, the risk of those procedures increase. So the biological clock of cancer usually ticks slowly. It's rare that the cancer happens overnight. It can happen, but it is rare. And especially for sort of a general and the typical colorectal cancer that we talk about, it takes somewhere between 10 to 15 years for a benign polyp, which is called adenoma, to transform into an invasive cancer. So more than 90% of polyps will never become cancerous. And as we discussed, for only a small fraction that they do, the transformation takes an average of 10 to 15 years. Why that matters is that for a 50-year-old or a 60-year-old who is in usual good health, removing a polyp is essential because that polyp within 10 years, by the time that that patient from 50 becomes 60, can turn into cancer and become a fatal cancer. However, let's say a patient in mid 80, let's say 85, if you remove a polyp, you need to go all the way to 95 in order to maybe see the benefit of that polyp removal. And that's extremely important for you to take into consideration. As we discussed, the benefit of screening is not immediate. It's an investment that takes years to mature. There's a term called time to benefit, and in colorectal cancer screening, that is somewhere between 5 to 10 years to prevent just one death from colorectal cancer for every 1,000 to 5,000 patients that were screened. So you need to at times take 5,000 patients for colonoscopy or other colorectal cancer screening, and then you need to wait somewhere between 5 to 10 years to prevent one death. So that is where that 10-year rule comes into play. So if a patient life expectancy is less than 10 years, let's say due to some health conditions like severe heart disease, it is more likely that the immediate risk of that screening is much higher than the benefit that screening provides. Obviously, we have multiple medical societies that do suggest and provide guidance and recommendation for colorectal cancer screening. We have USPSTF, we have ACS and ACG, and they are almost in agreement about their recommendations. So for patients younger than age 75, they recommend screening. For 75 to 85, 2 out of 3 suggest shared decision making, and all of them for age 85 suggest to stop colorectal cancer screening. That is a very simplified version. It is reasonable. However, again, if you are moving away from age, we need to be mindful about one's fitness. So let's say if you have a patient who is age 72, but they have severe cognitive impairment, and as a result of that, they are relying on the family for even their basic activities of daily living. Should you do colorectal cancer screening in that patient? The answer is more likely to be no rather than yes. On the other hand, you've seen patients who are in their mid 80s and they are extremely healthy, fit, active, sharp, very few illnesses, very few medications. They still work at times full time. And if you look at their life expectancy, it's more likely than not, unless there's a surprising event in the future, that they're going to live at least 10 years. So for those patients, still you may consider colorectal cancer screening. So these sort of guidelines are guidelines. They are not rigid sort of recommendations. And you may see a patient who is 86 who may act more like 76, and then as a result, you may need to engage in that shared decision making. There are two groups of patients and people that you may recommend much more strongly in favor of colonoscopy or against colonoscopy in that 76 to 85 age 85 group. One is a group of a never screened group, a healthy adult in his 70 mid 70 to mid 80 age range who's never been screened before, and in this patient and person, a catch-up screening might be very useful and helpful. On the other hand, you may have a patient in his mid 70s or early 80s who have had multiple clean colonoscopies in the past. Let's say the patient started at age 50, had one at 50, had one at 60, had even one at 70, and now at age 80, you may wonder whether there's any additional benefit to that colonoscopy, and the answer to that is probably no. So you need to take that into consideration when you're discussing with the patient, or if you're a patient trying to make a decision whether additional colonoscopies are needed for you or not. So obviously the mainstay of colorectal cancer screening still remains colonoscopy, and colonoscopy is not benign in an older body. So there are two categories of risk. One is the mechanical risk and the other one is pharmacological risk. So the mechanical risk happens as a result of a thinner, more fragile colon. So the risk of perforation is higher for patients over than age 80. That risk is about 1.6 times higher. Unfortunately, the consequence of perforation is not very appealing. It can lead to emergency surgery and sepsis. Also, these patients are at higher risk for bleeding. A lot of these patients are on blood thinners, antiplatelets like aspirin or anticoagulation. And even if you stop these medications, properly, you may still have a higher risk of bleeding during the colonoscopy. The second category of risk is pharmacological risk due to sensitivity to sedation. A lot of these patients may have some heart issues, so they may have cardiopulmonary depression, can cause, the sedatives can cause low blood pressure and low oxygen. Also, for patients with cognitive impairment, there's a risk of post-procedure delirium, which is a state of confusion after these procedures, and which can lead to some agitation for these patients. One of the most important thing is even a minor complication in these older individuals can trigger a domino effect of hospitalization, immobility, and infection, and at times can leave the patient worse off than before. But the third category of risk that is at times underappreciated and underrecognized is actually a day before the procedure, and that is when the patient needs to prep for the procedure. So patients are given a lot of laxatives in order to be prepared for the procedure. That can lead to some volume depletion and dehydration and lightheadedness and dizziness and falls, and also can lead to some electrolyte abnormality, like their sodium and potassium could be off, and that can cause some heart arrhythmia, and some vulnerable patients could even cause seizures. Obviously, the dehydration and lightheadedness and dizziness is a lot more common than seizures, but if you think about it, for a patient who has a gait and balance issue, who's on bunch of blood pressure medications, and now they need to prep by taking too many laxatives and having obviously frequent loose bowel movements, that's a major concern, and that is something that I'm always extremely fearful of, especially if I'm seeing an older frail patient who is being prepped for colonoscopy. Obviously, as we discussed, unfortunately, in some age population, there's an issue with memory. So PrEP can cause extreme distress, agitation, and dehydration in patients with cognitive impairment. And sometimes, despite patients and families' best effort, either the colonoscopy cannot happen, or it's actually going to be a very poor prep colonoscopy, which may not yield the result that everybody was looking for. Obviously, there are some additional tests like Cologuard, which looks for DNA methylation. The challenge for these tests is that as we age, the false positive rate of this test increases significantly. So for patients that are younger than age 65, the false positive rate is about 6%. But for patients that are older than age 65, that rate could be as high as 13 to 17%. So when you have a false positive Cologuard test, it can make you anxious, nervous. Then, as a result of that, you need to then proceed with colonoscopy, which then again, you need to go through the same risk as we talked about, and also the issue of life expectancy, etc. So you always need to be mindful about that. Unfortunately, the principles of decision making in this situation remains the same. The variables change a little bit. However, the principles of decision making remain the same. So how we can move from guesswork to data, and how we can actually make a truly individualized decision. So number one, we talked about life expectancy. We need to see which patient is more likely to live at least 10 years so that colonoscopy and colorectal cancer screening makes sense. Obviously, there are a variety of ways that you can look at it. There are mortality prediction indexes. A lot of these are available in ePrognosis website. You can go there and you can obviously incorporate some of the variables and get some numbers there. You can look at patients' frailty, such as clinical frailty scale, which is a 9-point scale measuring physiological reserve, and then obviously you can use some shared decision-making aids which facilitate conversation about risk and benefit, and it helps aligning medical choices with the patient values and preferences and quality of life goals. It's very, very important that for patients, caregivers, as well as doctors and care providers to know that when we ask about patients' ability to perform daily tasks like bathing, grooming, transportation, taking medications, handling finances, etc., we are not belittling the patient. We just want to have a much more comprehensive overview of one's life, of one's fitness. So based on that, we can then better predict whether the patient is more likely to live 10 years or not. So it's important to pay attention to those questions and answer those questions to the best of your ability. This is not something that you need to be running away from. You need to be shy from discussing your limitation, and you don't need to be offended if someone asks you whether you're able to handle your finance. It's important for you to know that these questions and the answer to these questions can help us help you much better. So a practical framework for screening decisions. So as we discussed, age 65 to 75. If you're healthy, definitely screen. Again, there's maybe 5, 10, 15% of patients even in that age category that are frail or extremely frail. You need to pay attention to that. Just simply because somebody is of certain age, you should not recommend screening, or if somebody is of a certain age, you should not simply based on that recommend against screening. Age 76 to 85, again, the issue of frailty and the fitness of the patient matters a lot. Shared decision making becomes extremely important in this age category, and you need to engage with the patient. You need to express the patient goals, fears, concerns, etc. And then obviously for age 85 plus, it's more likely that you're not going to recommend colonoscopy or other means of colorectal cancer screening. However, be mindful that you may see some super agers, some very fit patients. And the last thing that you want to tell to those patients is simply because they are 86 or 87, you're not offering colonoscopy or other means of colorectal cancer screening. You need to engage with them. You need to partner with them in order to come up with the consensus and agreement about how you should take care of that patient's health and well-being. So how you do that, how you talk to the patient about stopping colonoscopy. So as I mentioned, the last thing that you want is to tell the patient that simply based on their age, you're telling them to stop colonoscopy and other colorectal cancer screening measures. There are other ways that you can suggest that to the patient. So one is called the priority shift, and that is shifting the priorities from colorectal cancer screening to something that is more important and has much higher priority for the patient at the time. So imagine a patient very severe heart failure, or has very severe kidney disease, or has moderate cognitive impairment and is relying on the family for their daily routine. So you can frame it as at this stage, your heart condition is the main thing that we need to protect. A colonoscopy now poses a risk of dehydration that could hurt your heart for a benefit that is very far in the future. And I recommend that we focus our energy on keeping your heart strong. Why that matters is that you're not giving up on the patient. You're not closing the door. You're just simply telling the patient that instead of using your energy to prep for colonoscopy, use your energy, use the energy from your caregiver to focus on other issues that are much higher risk to your well-being and your life. So that's one way of mentioning it. The other way is the graduation script. So as I mentioned, there might be some patients that have had a bunch of colonoscopies and all of them have come back normal, and now basically they are going to graduate from colonoscopy. So you can use script like Ms. Smith, you have had clinic colonoscopies for 20 years. We can essentially declare victory against colon cancer. You have won, and we can safely stop this test now because you're safe. And it's very important for this script to see how the patient reacts to that, because it's all about probabilities, right? So although we think it's a lot more likely that this patient to be safe, but things can happen, and less than 1% chance that something may happen to this patient. So you want to make sure that the patient understands that you're not talking about absolute terms, but really at this point, the likelihood of you finding something serious for this patient is extremely unlikely. That is not worth going through additional colonoscopies. And then the third script is the legacy script. So this can be done in our goal is to keep you independent and at home. This test, like colonoscopy, carries a risk of complication that could land you in the hospital. I want to protect your independency by avoiding unnecessary risk. It's very important. So for example, if a patient goal is to stay home as long as possible, if they know that colonoscopy, even 1% chance of causing some complication and then leading to some hospitalization, some transfer to nursing home and other places, they would be able to go through some risk calculation and say, yeah, at that point, it seems that risk of colonoscopy is outweighing benefit significantly. There's also financial reality. So recent policy changes have removed key barriers. The old problem was a free screening that found a polyp would be rebuilt as a therapeutic procedure, triggering patients' costs. And as of 2023, Medicare is phasing out this cost sharing, and it will be completely eliminated by 2030. And now there's a complete screening benefit. So the old problem was the patient fear that a positive stool test like Cologuard would lead to an expensive diagnostic colonoscopy. So as of January 1, 2023, Medicare and other insurers are required to cover the follow-up colonoscopy after a positive non-invasive test at the zero cost sharing. So that these are some of the important financial realities and the new changes that we need to be aware of. So a new paradigm for protection. So the decision to screen in later life requires us to balance the biology of a slow-growing disease against the fragility of an aging body. The goal is not just to prevent death, but to preserve life. For a robust 70-year-old, screening remains a powerful tool for extending a healthy life. However, for a frail 85-year-old, the most protective act is often to withhold the screen, shielding them from a cascade of intervention that threaten their quality of life and independence. True protection in the golden years is about having the wisdom to know when to act and when not to. And with that, if you appreciated and enjoyed this lecture and presentation, I really appreciate if you subscribe to this channel, like this video, leave a comment below about your approach to colorectal cancer screening, especially in an age population. If you're a senior, if you're an older person, if you're an elderly, how did you approach colorectal cancer screening, especially as you were approaching, your 70s, 80s, or even beyond? How was your experience? And hopefully together we can have a society that not only preserves life, but also appreciates quality of life and well-being of our older adults. Thank you.